the discovery of disease biomarkers. Have had federal funding, I guess, since around 1990, but also recognize how incredibly difficult that has gotten over the years. I just wanted to share with you a couple priorities coming into the next several months of the EVPRI's office, make sure everybody's aware of them. The first one is the research strategic plan. I want to thank everybody who has contributed to that so far. You'll have more opportunities to review the work product, but all of the schools, almost all of the schools have completed the initial phase of the strategic plan. And I think that there's a lot of upside in crafting it still before the hard deadline we have, which is the second week of May. The second thing I wanted to tell you about is that the research park on Belknap campus, the RFP for consultants to help us plan the park, both physically as well as sort of the intellectual plan and the strategy. That RFP went out yesterday, and we've had already replies from a large number of consultants who are experienced in developing university research parks. So that's phase one is underway. We hope to have a report by the end of our fiscal year from the consultants, and then we'll start making some decisions. The president is intimately involved in this planning process and is, really very enthusiastic about it. And then last but not least, I just wanted to tell you just briefly, the office is putting a lot of effort into organization of existing cores, research cores, and that's an effort being led by Rand Haley and Kevin Merton. And we're making some progress in trying to bring some basic standards of practice to those cores. The other side of that is creating new cores, and the number one infrastructure priorities that we have in the office are the development of high performance computing to replace the Cardinal cluster, which is now quite old and quite outdated. And we're making progress simply by telling people that's our number one infrastructure priority. It gets their attention. So we're going to move forward with that in the coming months. And with that, I'm going to turn this back over to Lee Botner. At the end of the session, I'll stay on, and if people want to have a conversation, if you don't have to head out to do other work, I'm happy to do that at the very end. But Lee, because I have a terrible cold, Lee is going to introduce the speakers and move the agenda along.
Thanks, John. You don't sound like you have a cold, but I'm sure you feel like it. I just wanted to quickly pull up our agenda to remind everyone. We did have a couple of last minute changes. One of our speakers had a family emergency. And so Will Metcalf from our office is going to sort of take up some time that the other speaker would have shared with you. We will invite her back to another one. Today, we're sort of going to focus on community engaged and participatory research. And our first speaker is Dr. Kerr from the School of Public Health and Information Systems. And he's going to talk a little bit about his project that has an approach to addressing neighborhood factors that impact HIV care. And so I'm going to turn it over to Dr. Kerr.
Okay, well, first of all, thank you. Thank you for this opportunity to present, and I'm excited to be here today. Hope everybody is doing well. My name is Jelani Kerr, and I do a lot of work in the realm of HIV and looking at social factors that impact HIV vulnerability, particularly for marginalized communities. And so the the research I'm about to talk about today is part of uh, ongoing research that really focuses on um, looking at neighborhood factors and how that affects HIV vulnerability and what we can do and the effort we did to try to help address this. So let me share my window and put this on the big screen. Okay. Um, all right. So I think I have to go through this a little quickly, but let me start off with the good news. First, the life expectancy gap for HIV has decreased significantly. Um, Between 2000 and 2016, the life expectancy gap decreased from 22 years to 6.8 years. What does this mean? People who are living with HIV are living longer. Um, Also, the HIV rate has declined by 12% between 2017 and 2021. What has it? We've even gotten to the point where we have figured out that if people are diagnosed in a timely manner, promptly treated, um, giving given the medications and they are adherent to the medications, viral loads can go down and it makes risk of transmission essentially negligible. This is a concept this is a concept called U equals U, undetectable equals untransmissible. So what has happened was behind this news. A big part of this is that we have played in more recent years, we placed greater emphasis on the HIV care continuum. And what is this? These are the steps that people with HIV can take uh, to get access to treatment and to get to care and to eventually into viral suppression. Um, it's the process that I just described to you. If people are diagnosed, I'm sure people are linked to care promptly, that they're receiving care, that they're maintained in the care, and that eventually viral suppression is reached. Um, So a part of the problem, however, is that we're not really seeing the numbers and we would like to in terms of people's participation in the HIV care continuum. Um, while while there are maybe favorable numbers in terms of diagnosis and linkage to care, receipt of care is challenged, taking care is very challenged, and we definitely want to get those numbers for viral suppression up. Now, when we look at the data around some of the impediments to HIV care and some of the vulnerability around HIV in general, we're finding that um, behavior doesn't can't really fully explain what's going on. So one example I like to use in terms of why some groups may be disproportionately affected by HIV, than others is on the prevention side. If we look at condom use, we see that we see that African American women use condoms more than white women, but their rates are quite a bit higher. Black men who have sex with men have higher rates of HIV, but they engage in fewer risky sex acts. So this tells us that we can't really focus just on behaviors, including just getting people to the doctor in order to address HIV. This is when we have to start looking at some of these social factors, some of the social determinants of being engaged in the HIV care continuum. So this is when we have to look at things like stigma, racism, poverty, access to care. Um, so one of the things that we're looking at for this project are neighborhoods. Um, neighborhoods and HIV, this geographical assessment um, uh, of why of of HIV vulnerability and why people in some neighborhoods may be affected by others, more affected than others. There's data to support this. Neighborhood poverty is associated with elevated HIV incidents. One standard deviation change in racial segregation led to a 16% decline in new HIV cases. What does this mean? The more segregated neighborhoods are, the more vulnerable people may be to HIV. Again, and also areas that are disproportionately affected by mass incarceration also tend to have higher HIV vulnerability. So we have to start looking at place, and it's important to start looking at neighborhoods in particular to understand to try to address HIV. We did we did a systematic review a couple of years ago. Me and a team of people did a systematic review a couple of years ago looking at HIV neighborhoods and HIV prevention. This study is the natural jumping off point of neighborhoods and continuum of care participation. In order to answer this research question, we did a systematic review, um, and we adhered to PRISMA guidelines and Legend guidelines. Legend guidelines help assess study quality. So I have. So if we take a look at this graphic, we are finding that I'm not going to go through this whole thing, but ultimately we start with roughly 3,200 3,200 studies, and we were able to screen it down to 44 articles, and that's what were included in the analysis. Most of the studies were deemed, pretty good, optimal quality, but there were three that weren't deemed optimal quality, two because of small sample size, one because it was a qualitative study that was missing detail. So what were the results? Well, we found a few things. First, I call them four S's and an A. So socioeconomic status. This is in looking at the literature, we found that socioeconomic status, things like poverty, things like income, um, these were things that impacted people's continuum of care. Um, Stigma, segregation, social disorder, then the amount of crime in a place, the number of alcohol establishments, and on the flip side of that is social cohesion, things like civic participation, and lastly, people's access to care. Were people did people have transportation to care? Was care pretty far away? And so these were there's the article is this this study has been accepted by the Journal of Urban Health, and I got an email today saying that it will be released soon. So the article will be out in the very near future. Um, and there are some mediators in terms of race and like their differential associations with this relationship by race as well. And so, but now, but now it's important to talk about what happens afterwards. So sometimes when we do research, we just kind of post study and that's that's it. We're on to the next question, the next study. What we wanted to do was engage in a knowledge translation strategy, so that we could not just identify the problem and investigate the problem, but also, hey, let's work with community to find some solutions. And so that's what we did. We gathered people who were in the art world, who were in the HIV service sector. People who were medical providers who were treating patients who were living with HIV, people from the nonprofit sector, people from the media world, the art world, and we created this community advisory board. And they had the power to not just, and they had the power to help inform and design the intervention that we would create in the knowledge translation strategy based off of the data. So what we did was we came to our community advisory board and we said, hey, here's the data, here are our findings. We got, we got a little money to address this, and we said, what do you want to do? Well, the thing that people really latched onto was the stigma part of of our results. They were really concerned about stigma. Um, and so therefore, what they wanted to do two things. First, they wanted to address stigma among medical providers. Some people talked about how it's important for some medical providers to be, more educated about HIV and dealings with individuals who are living with HIV, and to just get the knowledge base up around some of the innovations um, um, in this area. So that was something for the medical providers. The second, and that is ongoing. Where like we're creating quizzes that we can provide to medical providers and people who take the quizzes, and we'll have medical education in there, and they'll get CME credits, and we're hoping to roll that out soon. But the other thing that they wanted to do was a podcast talking about sex, particularly the stigma around sex and some stigma around HIV. And we recorded we recorded 8 episodes, excuse me, in October, and we released at the end of last year. It's called Let's Talk About Sex. It's with the um, with our media representative on the community advisory board. Have some I have a couple clips I have a couple clips. I'll just play one in the interest of time. But this one is talking about from their episode about from stigma, STDs, and drugs reaching the head of the Kentucky Harm Reduction Coalition.
I'm not able to hear anything.
Oh, you can't hear anything?
No.
Oh, okay. All right. Well, we'll we'll keep moving. And
Okay.
I'm not quite sure how. Oh, wait. There's something that says share audio here. Okay, hold on.
No one will ever love me because of this.
Okay, I'll start over.
Because
Sorry,
I
y'all.
do have conversations with women about at what point do I disclose, whether it's HIV, whether it's herpes, or something that they have, like you said, taken on as a part of their identity. They're afraid to tell someone that they feel like I'll never fall in love with someone. Yeah. No one will ever love me because of this disease. So how do you counsel people? Like, I know you're saying, like, give it some time. You've got to just casually, you're dating someone, trying to get to know them. At what point would you say it's time to disclose?
Yeah, she was very open.
Okay.
I do have conversations with women.
Okay. All right. All right. So those are just some clips from the podcast. They're on Instagram, they're on Facebook, they're on YouTube. Um, okay, I sped through that because I wanted to be respectful of time. But this is funded by the Health Equity Innovation Hub, and supported by the National Institutes of Health and National Institutes for Mental Health through my K Award. So if you want to learn more and get more access to this, I can provide these links. And that is it. I think I'm within the time frame.
Thank you, Dr. Kerr. You're right. You did a very good job with keeping to the time limit. Does anyone in the audience have any questions? I haven't seen any pop into the chat. And I did put in the chat, if you didn't see, if you have questions for Dr. Klein, we may not be able to get to all of them at the end of today's session, but he would like to make sure that he addresses them. So if you would put them in the chat, that would be good. Any questions for Dr. Kerr? Well, I have a question. Oh, look, yeah, Fanny, I think he did say that he would provide the links to the podcast. And then I have one question for you, and we can move on after you answer this. Is there a way for any of the people within the audience that could tap in and potentially collaborate with you that may not be doing so? I mean, are there, types of expertise that you need that would really help with the work that you're doing?
Okay, absolutely. I'm always looking for collaborators who know about media communication. I have some grants that are coming up that are focused on HIV and using arts-based methods to try to raise awareness and try to destigmatize this. So I can put my information into the chat.
Yeah, that would be great.
Feel free to email me. I'm currently writing a grant that's looking at concept mapping and how that can be used to help formulate messaging and strategies to address, and doing this with community. Okay, I see your hand up, Dr. Klein.
Yeah, first of all, I want to congratulate you. I think we need more of an emphasis on community engaged research across the entire university. And so this is a great example of it. And I guess the second thing is that if you're looking for collaborators, I think everyone who does community engaged research should at the very least have a conversation with someone in the business school. They have real expertise in marketing ideas. I'm not sure it's a great fit, but it's worth a brief conversation. And also, if you're trying, whether it's you or other folks who are trying to attract individuals into your study, that they also have expertise in digital marketing that may be really useful for enrollment of people or attraction of people into a conversation. So, and don't want to forget the Community Engagement Academy as well. These are all resources for everyone who does research that from my mind, does what we do and what we're supposed to do, which is creating new knowledge to serve people. And I think I just wanted to congratulate you. I thought it was a really great presentation, and I think there are lots of opportunities for collaboration for you. And I see Rachel Shepard's hand is up.
Thanks. I was just curious because we have a lot of researchers that are doing HIV research on the biomedical side. Would there be advantages to, once you've engaged people in the community research and letting them know the other research that's taking place in the HIV realm? Because we do have a lot of, one comes to mind that we're looking at gut microbiome. So they might be really interested in contributing to the general knowledge around treatment or management of HIV as well. So just wanted to put out there that we might want to encourage, tying the two together, that once we have the community members engaged, we should continue to give them more avenues to be a part of research.
Okay, thank you for that. Yeah, I'm on the gut microbiome study team.
Oh, good, perfect.
Yeah, and we are. It's an interesting collaboration with the medical school and social work. So we're trying to find ways to make sure that we integrate community well into it. So yeah.
Great.
Okay, so the chat, so the link is in the chat. There's some graphics there. Remember, this isn't necessarily for academic audience. It's for community, and this is what people wanted. So that's fine.
Thank you very much.
No problem. Thank you.
So our next presenter is Dr. Brad Campbell from the College of Arts and Science, and I think you're going to find his topic and his research very unique and exciting for him to share with us. He's going to talk about trauma-informed interview training for sexual assault investigators using standardized actors. So Dr. Campbell, I'm going to turn it over to you.
Great. Thanks, Lee, and thanks for having me, and thanks everyone for joining at lunchtime. That's exciting to have this many folks here. So yeah, I'm Brad Campbell from the Department of Criminal Justice in Arts and Sciences, and today I'm going to present on behalf of my research partner on this, Rachel Carter, who is in Arts and Sciences Theater Arts, and James Root, who is our training instructor and training expert from the Attorney General's office and formerly of the Department of Criminal Justice Training. And if you see all four of these logos at the top of this slide, you might be thinking, is this shameless self-promotion for our program and for my research partners in the field? And the answer is yes, but it also shows our kind of unique partnership where, as a criminal justice researcher, we were able to work with Theater Arts and the Department of Criminal Justice Training, which is our state's primary provider of police training, to develop an innovative police training program to teach officers how to do trauma-informed interviewing and evaluate their performance using standardized actors. So just to give a little bit of background on this, the problem that we're focusing on and how this kind of came about in our research is across the country, there's a problem of case attrition with sexual assault cases, meaning that the majority of them do not end in arrest. Also, in the last 15 years, jurisdictions all over the country have identified backlogs of untested sexual assault kits, which hold DNA evidence that could, hold offenders accountable for their actions and bring justice to sexual assault survivors. So in 2015, when Kentucky identified their backlog of untested sexual assault kits, the state started to take pretty innovative steps and lead the country in improving responses to sexual assault survivors. And one of the areas of focus that they honed in on was training for police officers. So if we look across the country, what we know in this kind of circle of cyclical problem here is that there is limited or no training for police response to sexual assault survivors. That limited or no training can lead to people to make decisions based on a lack of knowledge about how to effectively engage with survivors and based on misperceptions about survivors. That can lead to poor responses of survivors and re-victimization. And that translates into reduced survivor engagement, which gets back into the problem of case attrition. So in 2017, the state of Kentucky decided to try to combat that problem, and James Root, who was the instructor for the Department of Criminal Justice Training at that time, developed a 40-hour training program that every agency in the state had to send at least one officer to. And I was lucky enough to partner with the state to do an action research approach on their responses to sexual assault survivors. And a part of that, we evaluated this initial training program on sexual assault investigations to see if it affected their knowledge and perceptions about sexual assault survivors and sexual assault investigations. And those two green thumbs up means that the evaluation found the training had a significant effect on both of them. Because this was an action research project, I sat down with James Root and the command staff at the Kentucky Department of Criminal Justice Training, and we started to try to assess what's next. And part of our evaluation included a needs assessment. And in that needs assessment, we found that officers in our state wanted more survivor interview training programs. So as a group, we sat down and we started to try to think about how we could develop effective police training programs for officers in our state to interview sexual assault survivors. And what we know from research and from talking to folks is that most police training is going to have lecture-based instruction with some case examples. And in some situations, they might have police officers act as a role player. So maybe it's somebody during a traffic stop that a learner or an officer in the class would have to engage with to practice their skills. We know that some of that training can improve knowledge and perceptions, but a lot of times the lecture-based training doesn't translate to change behavior in the field. We also learned that officers that we talked to throughout the state say that traditional police training with this lecture-based model causes a slow death by PowerPoint, which we know, we've all experienced training programs where we've got a PowerPoint thrown at us with lots of information. So what we decided was missing from that model, and what the research shows is missing from that model with police departments and police training, is human interaction, and particularly human interaction with non-police officers. That's important because 99% of the individuals that police officers respond to in the field are not police officers. So through taking that knowledge in our conversation with officers and instructors, I thought back to a barbecue that a colleague hosted here at UofL, where I met Rachel Carter from Theater Arts and explained to her that I do police training research. And Rachel talked to me about the idea of standardized actors in medical training. And if you're in the medical field, you know this already, but for those of us who are not, standardized actors, very common training method in medical training for doctors and nurses education. What it does is it allows course content and the learning of skills and communication to build to an interaction or capstone. And in that interaction or capstone, they're going to use trained actors to portray patients who follow a script based on real cases, real symptoms, and real problems. Based on that script, the actors are trained to provide different levels of information and change their behavior or their rapport with the learner, the doctor or medical or nursing student, based on the bedside manner that they're using. So if they have good bedside manner, they get more information and have better interactions. And the opposite's true if they don't have good bedside manner. And then those actors are also trained to give feedback based on course objectives and their feelings as an individual during the interaction. What the research shows is usually training with these standardized actors improve their behavior in the field and their confidence to carry out skills. And for me, this really resonated with our policing research because these are the types of things that we want officers to do. We want them to apply their skills, practice them, get feedback on their skills from non-police officers. So what Jim, Rachel, the Department of Criminal Justice Training, and I did is we created a 40-hour trauma-informed interview training program. And that program is going to couple lecture-based curriculum in which we teach officers about misperceptions of survivors and how those might affect their judgment and how they may be linked to case attrition. We also discussed the neurobiology of trauma for police officers, particularly things like how vicarious trauma affects their brain, and also how critical incidents affect them, and effective responses to those for police departments that police department policy mandates, and how we would like that same response and that same knowledge to be applied to sexual assault survivors or other crime victims who they come into contact to, because the neurobiology of trauma is very similar for both groups. Then we taught them about trauma-informed care and compassionate responses from the field of social work, from SAMHSA's 4 R's of trauma-informed care. And we taught them cognitive interviewing, which is an investigative interviewing technique that teaches officers to ask questions in an open-ended manner. That couples well with being trauma-informed because it avoids those traditional interrogation-style interviews that officers may be taught in other training courses. We added the standardized actor interviews with this following the medical model to create our standardized actor scenarios. We created scripts that were based on actual sexual assault reports. We pre-tested those scripts with sexual assault survivors, police officers, and victim advocates to try to make them as realistic as we possibly could for our officers who are going to attend the training. The actors were taught based on the script to respond based on questioning style. So if investigators use traditional interviewing techniques or interrogative techniques, they received less information and had less of a rapport with the actor. if they use trauma-informed techniques and cognitive interviewing skills they had, they were instructed to give more information and have better rapport. And then we trained those actors to provide feedback based on course objectives and their feelings as an individual. To evaluate the effectiveness of this program for our National Institute of Justice grant, we were able to randomize the 8 classes that we had funding to offer. We randomized them into treatment and control groups. The treatment group did surveys and interviews after they received the training. The control group did surveys and interviews both before and after the training. So in this design, that allows us to compare the post-training surveys and interviews from the treatment group to the control group surveys and interviews. For the control group, they showed up on day 1 of the training. After a brief introduction, they completed a survey, and then they went in and did a mock interview with the actors. We used this design to answer the 3 research questions for our study, which was, does the training improve knowledge and confidence of using victim-centered trauma-informed interviewing techniques? Does the training improve behavior based on our ratings of officer scores in those video recordings of their interactions with actors? And then what were officers' perceptions about the simulations? Were the officers, did they view it as something that was useful and realistic? So for our experimental evaluation and outcomes, I'm going to show some bar charts. And on the left in the bar charts is the treatment group, and on the right is the control group. On the first graph that we're showing, we've got survey outcomes. So we wanted to know, did it improve knowledge of trauma, and did it improve confidence to interview? And in this case, in the first set of columns labeled knowledge of trauma, a lower score is good. That means it improved officers' knowledge. It reduced their misperceptions of trauma. So we've got a green thumbs up for our statistical significance measure there, indicating that it did significantly improve officers' knowledge. In terms of confidence to carry out the interviews, it also increased officers' confidence, which is good because if we know from research that if officers know how to do something and they're confident in doing it, they're more likely to do it in the field. In terms of measuring behavior, we used rubrics based on course objectives to score officers' performance in video recordings of mock interviews with actors. And in these 2 bar charts, we have use of trauma-informed techniques. That significantly increased in the treatment group compared to the control group. And their ability to obtain information from the actors also increased with the treatment group in comparison to the control group. We also asked officers about their perceptions of the simulations. So we asked them to rate their agreement with 3 statements on a scale of 1 to 6. For the first one, the simulated interview improved my confidence with interviewing sexual assault victims. We have a mean rating of 5.69. Simulated interview improved my training experience. That's 5.8 out of 6. And then the most important one, I think, which really shows how well Rachel and her theater arts team did on these simulations, is based on my experience with crime victims, the simulated interview was realistic. And on that, we had a rating of 5.75 out of 6. In terms of what the officers were actually saying about the class, they enjoyed the interactions with the actors. So one officer said, the feedback from actors made me rethink how I ask questions. So in these cases, actors would say to them, when you ask this question, it made me feel believed or it made me feel blamed. And based on that feedback, officers were able to retool how they could ask questions in the future. The second one, it was night and day difference between taking a book class or lecture class versus hands-on actually using a role player and working with their personality. That shows that this officer indicated that having this type of training avoided that death by PowerPoint class and gave them something to build to and interact with in their class so they could get actual hands-on experience before going back in the field. And the last one said that they thought the training with the actors that we offered should be fundamental for all new officers and investigators. So based on these kind of positive outcomes from the study that we did, we know that overall training is effective. The officers enjoyed working with actors, and Rachel Carter's working on a study that did focus group with the actors and asked them about what their perceptions were about interacting with officers. So what we're doing right now is we're continuing to offer investigative training with actors. We've got a 24-hour trauma-informed interview class and a 40-hour cold case and survivor notification class that's funded by the Bureau of Justice Assistance. And we're applying for grants to measure behavior in the field to see if we can set it up so that we can offer the training and then see how it affects officers in the field. In terms of areas for collaboration, right now I'm work with the Southern Police Institute, which is housed in the Department of Criminal Justice. And the Southern Police Institute is a national police leadership and education and training institute. It's one of the oldest in the country. It's been at UofL since 1951. And we're working on creating, we have it under review right now. So if you're on the committee, please approve us. Just kidding. But we're trying to create the Train Center, which would allow us to have more training, research, and innovative simulation in police training. And then the last, another area for collaboration would be to work on interdisciplinary training and different modalities. So we want to add actors to existing Southern Police Institute training courses and add virtual reality. So I see Adil El-Maghrabi on here, and there's also Faisal Aklan from engineering, who we've talked to about adding some VR simulations to our trainings. We're going to add this to other types of training programs like de-escalation, domestic violence response, and potentially traffic stops and things like that. And then we'd like to add it to interdisciplinary training as well for victim advocates, for prosecutors, and co-response for criminal justice practitioners and social work and things along those lines. And that ends it for me. And hopefully I also stayed in the time limit.
Thanks, Dr. Campbell. Yes, you did good as well. I'm very impressed with the speakers today. Does anyone in the audience have any questions for Dr. Campbell? Your research to me is very exciting because it's very different than what we typically sort of showcase here, and I enjoy hearing other types of projects that are going on campus. It looks like a couple of people are putting one person that the COB has started a new leadership program with the LMPD and Kentucky State Police, and you may want to reach out to Virginia Denny if you haven't already.
Okay, thank you. We can do that. There might be some collaboration for the Southern Police Institute with them as well.
All right, we are at about 12:45, which means we have about 15 minutes left. And Dr. Metcalf, Will did indicate that he would be happy to talk, but I also wanted to give everyone an opportunity before we turn it over to Will to ask Dr. Klein any questions that you may have. I didn't see any in the chat, but if you are interested in asking him some questions, feel free to raise your hand.
Well, that's okay too.
I think Dr. Gregg has a question.
Hi, Ron.
Hi, John. Sorry, I missed the first half. You may have covered this. I was just wondering if there's any update on compute capacity.
Yeah, I did mention it. It is the #1 infrastructure priority for the EVPRI's office in this budget cycle. We are walking around with our monk's begging bowl. And so far, some people have put a few crumbs in it, but we are making progress. As you know, it's the consultants that we brought in, the final report indicated that we needed, just for the first year, about $3.75 million. Kind of a heavy lift around here, but I'm optimistic that we're gonna achieve a replacement of the Cardinal cluster with a state-of-the-art system, and then be able to hire people or pay people who are already here to administer it and manage it. It is, I can't say it too many times. It is the number one infrastructure priority in the EVPRI's office.
That's fantastic. Thank you.
And I just want everybody to repeat sort of my mantra when it comes to the Cardinal cluster, that when we purchased it and stood it up, it was the same year that the very first iPhone was released. That's all you need to know about this topic as to why we have to replace it. I think the president, she may fire me if I say that one more time. Nah.
It looks like there's one more question that Dr. Jones has indicated in the chat. What is your goal vision as the interim EVPRI? Sorry.
That's a really, that's a good question, and sort of as an aspiration, I want to produce a research strategic plan that has a sense of urgency and much greater ambition than we have previously articulated in the university. I've been here since 1982. And if there's something that I've always found frustrating, first as a young faculty and now as an old faculty, is the sense of urgency is not there in many instances. And we have, sometimes way too limited ambitions. And so the strategic plan that will be coming back for comment is going to include some fairly ambitious things. I also know that this university, that when you propose ambitious things like cluster hires, for example, that there's a cynicism because strategic plans by and large get written and then put on a shelf to gather dust. Um, I'm I'm hopeful that this one will be different because the president has insisted it has to be different, and it insists also that the plan should be linked to the resources that are necessary to accomplish the more ambitious goals. And that's encouraging as we're heading into a capital campaign. It's been over a decade since we had a capital campaign. So if I can link research goals that are very aspirational and ambitious to the capital campaign, and I'm obviously not going to go into detail what those are. You're going to all get a chance to see, the version of this. It's going to be posted on the EVPRI's website for comment. But we're listening to what was sent to us by the academic units, and then if it's, I'm sorry to say it this way, if people are sort of, limited in their ambition because it's been so frustrating here and what we've lived through, we're going to pump up that ambition in what comes back for future comment.
Thank you, John. And especially on that last part. I mean, I think shows a depth of insight there that is real. It's not just a hypothetical. I think that, in time there may have been limitations, but thanks so much.
Okay. I guess Margaret is asking, is there a link to the research strategic plan on that website? When there is a research strategic plan draft, and it's reached the point where we're going to put it up for comment, it will absolutely be on the website. We discussed this yesterday, but we are, the timeline that was laid out was overly ambitious. Initially, the responses from the academic units, somebody correct me, but I think we had 8 or 12 weeks, and then it got pushed out to 16 weeks. That's really not, enough. So we have stretched this into the spring semester, and we are taking the responses from the academic units, and not an easy thing to take strategic plans from units as disparate as we have, and you can, on the one hand, you can say it's a very rich intellectual environment, which I think it is. On the other hand, trying to hammer those into a unified plan is no small thing. And Cindy Logston's leading that effort, and Will Metcalf and and Kevin Merton are a part of it. And in fact, the whole office is. But trying to weld that into something that's good communication is not an easy thing. But as soon as we think that it's digestible and understandable, we're going to put it up there on the website. Okay, Will, you wanna wind us up here, and then I do have one last comment when you're done.
Yeah, thank you so much, Dr. Klein. So about a year ago, and also thank you to the presenters today. Outstanding presentations and information shared. Really exciting work in the community engagement space. Just wanted to give an update on our industry engagement efforts. About a year ago, we brought in a director of industry partnerships with the intention of supporting industry engaged research. So I think this highlight is a right time to do it with the focus today on community engaged research. And so I'm just going to share a few slides around successes we're having and where we are in the process for engaging the community, the industrial community, and our research enterprise here at UofL. The goal of this is really to share holistically across the university with the industrial community how we can partner. And when we say that, we mean it's more than just research, but research and talent for companies and philanthropic opportunities and executive education, all the ways the University of Louisville can support economic growth and vibrancy of our corporate community in Louisville. So these are some of the ways we think about it. Sponsored research, obviously, student engagement, faculty engagement, executive education. We think about it here in the Office of Research and Innovation for licensing of technology and tech transfer, startups and co-location with the new research park that Dr. Klein mentioned that we have an RFP out right now for consultants to help us build out that plan for location of companies close to the university. So over the last year, we've validated the interest in this from some of our largest corporate partners in the city, UPS being a primary example of that. So we all know about UPS. We have the longstanding Metro College partnership where students get access to tuition and they get to work at UPS while they're here. This is a great opportunity for UPS to access talented students to fill jobs that they have to have filled, but also provide great tuition benefits to the students here at UofL. But building on that, we've never really had real deep research engagement at UofL with UPS over the last 20 years. And so this first investment that we were able to get this year of about $1 million is going really well. It's focused on robotics and automation and package handling, as you would expect. That would be UPS's interest. And it's ahead of schedule and it's going really well and they're happy with it. And we think will continue to receive investment in research, specifically robotics and automation for package handling from UPS to do that work. So they're kind of engaged across these areas. Obviously, with student employment, research and innovation, they're supported a couple of big grant proposals that we submitted to the National Science Foundation with letters of support. So it's a really fruitful partnership, and we're continuing to lean into that. And that's really why we brought the Director of Industry Partnerships, Lori Young, in, is to help us manage these big, important relationships in a holistic way. Another one is a company called ISCO. And so ISCO is a manufacturer of a specific type of piping here in Louisville, Kentucky. They're a great corporate headquarters here in Louisville. A lot of people don't know about them. $700 million a year in revenue. And they had a specific need for research to help in their production process of this pipe. And we are, again, ahead of schedule. It's a small contract. It's only $35,000, but we already have our second engagement with them on research, which is probably going to be a larger contract with them. They also are on several advisory boards for us now, and they are hiring students in ways that they hadn't before. So I just wanted to give these examples of why we're doing this work. We're going to be expanding into more healthcare engagement this year intentionally with the corporate community. But just to know that we are being successful with this process. Again, these are some of the companies that we plan on engaging really deeply, and the strategy that we've laid out with leadership here to do that corporate engagement. And some of these, the star here indicates where we already are having a lot of success with that engagement process. And then Salesforce is being rolled out. And I'll stop there because Dr. Klein, I know you want to say a few words, and we've only got about 2 minutes. Salesforce, for those who don't know, is just a CRM, a customer relationship management tool, where we can really understand in a snapshot the whole engagement with the company. And that's a big effort for us. We're rolling that out here in the Office of Research and Innovation. So I'll stop there.
Thank you, Will. And just everyone understand that our corporate engagement team is actually, just really like a hidden jewel. I mean, they are doing amazing things where for many years we simply talked about corporate engagement. And now we're starting to see it happen, and it's resulting in research dollars, in student stipends, and a lot of things that sort of are a virtuous cycle in the way that we interact with the community. Last thing I want to do very quickly is mention that we are developing a process for cost share for large multi-investigator grants. We're going to have essentially a pathway that can be followed very easily. It's going to be standardized so that some of the haggling and back and forth is going to be unnecessary, because I know when I was writing, a large multi-center investigative grant in the fall, that back and forth with the EVPRI's office was distracting from writing the grant itself. So we're going to simplify that process. It's going to be posted on our website. It is going to be a lot more straightforward than it currently is. It will also have some time marks on it. It is, we want to be supportive of everyone, but to be honest, the tendency of people, rarely, fortunately, to ask for letters of support or letters of commitment, which are much more involved because they involve money, to ask for that and to do it the day before the deadline is not in the best interest of the grant, not in the best interest, therefore, of the PI, and certainly not in the best interest of the university. So we're going to ask people to work a little earlier on those things, but by simplifying it, I think it'll be possible to work earlier. And so just keep an eye out on that. We're still writing that policy, but we'll make sure that everyone is aware of it. That's all I got.
Thanks, everyone.
Thanks for attending. Bye-bye.